Fairooz. At her age, she is having extensive national and international experience. She was trained at LV Prasad Institute, later on with Dr. Sheets. She has worked in Hong Kong and China, and now she is heading, I think, in Dubai also, Ocular Oncology department there, and she is working, of course, at her own setup in Bangalore. So, Dr. Fairooz, uh, today she will be speaking on multimodal treatment protocol in ocular malignancies. Yeah.
Thank you, Dr. Mukesh, for the kind introduction. And I take it a privilege to be able to stand here in this podium with the stalwarts, both our international and national speakers. My topic for today, I chose it for a reason, that is multimodal treatment protocol in ocular malignancy. The aim of this topic at this point is to advocate for my patients as well as for the specialty as ocular oncology. These are my affiliations, current and past, and that's my financial disclosure. So going on to a very treacherous and a lethal malignancy, that is adenoid cystic carcinoma of the lacrimal gland. Back in 1986, Henderson has already published that this is the most treacherous and the lethal tumor of the orbit, where the lethality is accounting to 80% as far as mortality is concerned, and up to 80% again metastasis is concerned. Let me take you through a case scenario here. This patient was recently, this was like 2 weeks back, was referred to me for an exentration prosthesis. Well, we fitted an exentration prosthesis for him. He was a patient from abroad. Now, taking back to what the case scenario was, he had a lacrimal gland swelling, lacrimal gland lesion, a tumor in his left eye. A lacrimal gland incision biopsy was done in him with head and neck surgeon, and an exentration, which was bicoronal and bilateral neck dissection, was done in him. This is how the patient was managed, and finally, he just came in for an exentration prosthesis. Taking you through another case scenario. This was again a young patient in his late 20s. I saw him in November 2024, where a year back he has undergone lacrimal gland incision biopsy. It came out to be lacrimal gland adenoid cystic carcinoma. He received just orbital radiotherapy. After a year, at this point when I saw him, he had a mass still there, filling the orbit. The vision was 6/12, and this is the residual lesion after just a radiotherapy for a lacrimal gland adenoid cystic carcinoma, and it was almost coming up to the posterior orbit. In 1 month time, in January, he came back because we were discussing with the tumor board. The vision has come down to counting finger, half meter. So the tumor has been progressing despite giving just radiotherapy to the eye for a lethal and treacherous malignancy of the orbit, that is lacrimal gland adenoid cystic carcinoma. And this is a follow-up of 17 months. And he has noticed a progression despite radiotherapy in 6 months. Now, we do have challenges in the management of adenoid cystic carcinoma, and as ocular oncologists, we recognize that. So basically, there is a very complex regional anatomy in the orbit, aggressive behavior of the tumor, perineural infiltration. Most of these cases, they have hypoaesthesia. It's known to create hypoaesthesia in the forehead and stuff because of the perineural infiltration. Hematogenous and lymphatic spread. Long term, they can land up with metastasis, and most commonly, 45% of these patients have lung metastasis. And there is a lack of effective treatment protocol. Well, so we do have, evidence from literature how it was treated in the past. Well, this is a case where the patient was treated with exentration and radiotherapy, a combination, and still a 5-year survival rate was less than 50%. Dr. Say also did exentration and radiotherapy with 43%. Well, Dr. Say from Baskin Palmer also included intra-arterial chemotherapy in order to chemoreduce the tumor, but still the prognosis was not that great as far as life salvage was concerned. Now, this was when I was doing my fellowship, because Dr. Honavar had a gold mine of data. So we kind of thought about whether we can conserve it and yet improve the life salvage. And mostly we see young patients presenting with these, and in due course of time, where they're going to live for 50 years, they might land up with metastasis as well. So it's kind of salvaging the life and, of course, giving them a good quality of life by conserving the eye and the vision as much as possible. So he started his data collection way back in January 1995, and then we deep dived into it from 1995 to December 2015. So we had evolved in the treatment of adenoid cystic carcinoma of the lacrimal gland. So initially it started as surgery and radiotherapy. The outcome was not that great. Then, whether we can add something more and improve the outcome, then adjuvant chemotherapy was added in the group 2. And finally, at this point of time, we all follow neoadjuvant chemotherapy, surgery, radiotherapy, and adjuvant chemotherapy. I was fortunate enough, again, to be part of the study. So what we identified at this end of the study was patients of group 3 receiving neoadjuvant chemotherapy for chemoreduction, and then going for a complete surgical excision with a clear margin, then again beating the orbit up to the cavernous sinus, where the whole tumor is primarily involved with the primary presentation. You give radiotherapy, and then again adjuvant chemotherapy. Adjuvant chemotherapy, we believe, takes care of the systemic micrometastasis, and our mortality was just 7-8%. And most of the patient had vision salvage, and we could avoid exenteration in group B. So how do we do it? I'm emphasizing, when the patient presents with a lacrimal gland swelling, we go in for an incision biopsy, prove that it's lacrimal gland adenoid cystic carcinoma, neoadjuvant chemotherapy, and then when the tumor is consolidated, we go in excising it, complete excision with margin-free radiotherapy and adjuvant chemotherapy. So this is what we have adopted, and this has been published. Now, so we can conserve and yet improve life salvage, and that is what we came up with this particular study. Now, going on to another malignancy of the orbit, most common in children up to 10 years of age. This was an unfortunate 23-year-old lady who was, again, came from abroad for treatment. She had this large tumor sitting in the orbit where she was actually advised exenteration, and then further the patient was not willing for an exenteration, came for a second opinion and referred to me whether you can conserve. And I said, okay, we can conserve, because rhabdomyosarcoma already has a proven protocol which has been used by medical oncologists, pediatric oncologists, and ocular oncologists. So the basis of treatment in rhabdomyosarcoma is maximum tumor debulking. You remove it as much as possible, and then the patient receives chemotherapy, radiotherapy, right? So I went ahead, excising this, not an exenteration. She already had a perforated cornea. As you can see here, the globe is compressed. This is not the globe, this is the tumor, and this is a small globe which has been perforated, and well. So what I want to emphasize here again is there is definitely time-tested proof and evidence that in many of the lethal and bad malignancies of the orbit, or even the body, the breast, the lung, and other parts of the body, it's a sandwich and a multimodal treatment protocol that we adopt in order to get a good outcome. And of course, the primary outcome is life salvage. Now, with rhabdomyosarcoma, we have group 1, group 2, group 3, and group 4. Now, group 1 and 2 does really, really well, because the aim is to clear it surgically. So whenever you have a patient with rhabdomyosarcoma, maximum clearance is very, very important, and that's how the outcome is considered. So this was a patient who underwent the entire series of treatment, starting from maximum removal of the tumor, chemotherapy, orbital radiotherapy, and again, chemotherapy. It's a long cycle of chemotherapy that these patients continue. And we do have proven evidence from different papers that the survival rate, especially in embryonal rhabdomyosarcoma, with this multimodal treatment protocol is as high as 94%, and without, it is as low as 40%. Well, this applies to our retinoblastoma patients as well. This is pre-treatment. We give neoadjuvant chemotherapy ptysis, when the globe is completely regressed and the orbital component is regressed, we enucleate, we give the radiotherapy, and again, we give the intensive multimodal treatment protocol, which also include a new adjuvant high-dose chemotherapy for a total of 12 cycles. So we have seen also in retinoblastoma, with an intensive multimodal treatment protocol, the survival has been 95%, which has been dismal in the past with conventional treatment of exentration to 0 to 5%. So my advocacy today here is, despite evidence repeatedly being published, we do come across such cases where it has been conventionally treated. And I think as a whole, as specialists, we need to identify which are these patients who has to be given multimodal treatment protocol and correct referrals. And as an ocular oncologist, I think we have, future perspective to explore in order to improve the outcome of these patients. So I would propose chemoreduction, surgical clearance, radiotherapy, and chemotherapy as a multimodal treatment protocol in most of these lethal malignancies of the orbit in order to save life and conserving the quality of life of these patients. Thank you so much for your patient listening.
Thank you,
thanks to
Dr.
Dr.
Fairooz.
Hunavar for giving this platform.
Yeah.
Thank you so much.
So this brings us to the end of all talks. And